This is the computer system I alluded to yesterday. So all of you who want to see, you put your cursor on the age, you put your cursor on the concentration of creatinine, and you put your cursor on the weight, and immediately your computer is calculating the GFR, the body mass index, and you have an enormous amount of information, which is very correct according to the MDRC formula. So on your desk, while the patient is sitting in front of you, you have his GFR, you have his body mass index, and this is a very important information. So it's available for you. All of you who want that, it takes me, you send me an email and you send back the software and everything what you need. Now I will speak about cardiovascular disease. So I make a propaganda for that because it's so useful to have that information on the spot, immediately, without all those calculations. And it is, and if you're an Afro-American, if you have an Afro-American, you can click on that, and that will adapt the formula to the Afro-American. But I think, and you have the sex difference, the age, body weight, and the age, and you have all the information. Yeah. So we are in a hurry for the cardiovascular. I will try to do my best to be in time. So, first of all, this is the program. At what stage of CKD does cardiovascular disease is important? And we will discuss briefly, if you have the time, what are the underlying pathomechanism. I will go very briefly over that. Then the cardiomyopathy, which is something very specific, sudden death, and then the intervention. But first, as an introduction, I want to say that when I teach to my students in medicine, the nephrology, I start by saying that nephrologists have introduced new diseases. We have invented new diseases, and this is one of them. Another, for example, is a beautiful example, is aluminum toxicity. We don't know anything about aluminum toxicity, and since we let survive patients with end-stage renal failure, you give them aluminum, and you accumulate aluminum, and you induce encephalopathy, bone disease, anemia, all new diseases which were absolutely unknown for the society until nephrologists came onto the scene. So that's another example from all the organs in the body suffering from end-stage advanced renal failure. The heart is the most important target. So it's not surprising to see that the death rate of our patients in dialysis is mainly cardiovascular and also those of end-stage renal failure. So this is, for example, what is going on if you look to the mild renal dysfunction and association with coronary disease, and you see the curve is going up as soon as you have a decrease in renal failure. And this is, the schemes, which is combining the proteinuria and the GFR, and you see that when the GFR goes down and the proteinuria goes up, the risk to develop cardiovascular death and cardiovascular events is also increasing. And this curve, this fantastic, dramatic curve, where you see the age of and survival in a normal population, and here you see the survival in the dialysis population. And you see that at young age, the drama is here, that between 25 and 45, you see that the difference in survival is dramatic between the normal population. Again, incentive, a very dramatic incentive to transplant your patients particularly when they are young, because the survival and transplantation is certainly vastly superior. What are the mechanisms? I will not go over that, but just show you what is, for those who are interested in, and you can use the slides for the lecture, several mechanisms have been put forwards. In addition, the end-stage renal failure is a pro-inflammatory state, we know that, and this has been said already several times, is a pro-thrombotic state due to several factors which are clearly increased in those patients. And here I introduce something new, which I think is very important. There's a wonderful paper of 1 year ago. Is the fact that FGF23 induces ventricular hypertrophy. So that's typical renal, because FGF23 is not increased in nobody with a normal renal function of just GFR between 120 and 80. Once you have a GFR below 60, 30, etc., the FGF23 increase. And these experiments shown first, this is epidemiology showing that when you have a high FGF23, you have a very high risk to develop cardiac ventricular hypertrophy. This is all epidemiology, very well done. And this, then the guys, they have given to rats with renal failure, without renal failure, all the controls were there. They have injected FGF23. And the rats develop hypertrophy, dramatic hypertrophy. The control experiment has been, they have given an antibody to FGF23, neutralizing FGF, and there was no cardiac hypertrophy. And they have given a drug blocking the function of FGF23 pharmacologically, and there was no hypertrophy. So this paper is a marvelous paper, clearly indicating FGF23 in itself, without Cloto, is able to induce ventricular hypertrophy. So that's what I call a typical renal toxin. And FGF23 can be considered. I tried to defend FGF23 a little bit yesterday as a defense mechanism for the initial phase of phosphate retention, and that's correct. But once it's going up, at the end, it becomes really a toxin and can induce ventricular hypertrophy. So that's for the mechanisms. Coronary heart disease, okay, we know that calcified plaques, and I will go on that more extensively this afternoon when I speak about vascular calcification and calcium, that the ratio between no renal disease and renal disease is dramatic, and we know that, and it's not only the case in dialysis, particularly in dialysis. The multiplication factor in the development of vascular calcifications, once you're in dialysis, is dramatic, and I will give you a hypothesis, a very solid hypothesis, why that is the case. The reason, again, is a lot of things pro-inflammatory, I said already, I'm repeating myself, and the absence of anti-inflammatory. There are a lot of factors we're trying to be anti-inflammatory, and that's fetouin. Fetouin is a protein which is trying to neutralize the calcification, and fetouin knockout mouse develops a dramatic calcification everywhere in the body. It's like pyrophosphate. Pyrophosphate is a beautiful molecule. There are now trials going on using pyrophosphate in the treatment of vascular calcification. Fetouin is another one. There is an increase not only in inflammation, but also in a lot of factors responsible for fibrosis. I'll come back to that very briefly. Hypoxia sensing and hemorrhage promoting factors are present in the renal failure patients. And finally, there is an increase in apoptosis, and you will see that this in the heart is also present in uremic conditions. So what is cardiomyopathy? Cardiomyopathy consists in renal failure by a dropout of the cardiomyocyte. We lose our cells by apoptosis, I don't know, but this is a fact. An inappropriate hypertrophy, I also alluded to that. Interstitial fibrosis and microvessel disease. I will briefly discuss that. So if you have, you do an experiment, you single nephrectomy, you see that immediately the number of cardiomyocytes are going down. If you treat that with Ramipil, apparently in this experimental condition, you can restore that. The cardiac hypertrophy after subtotal nephrectomy remains despite prevention of hypervolemia, prevention by blockade of alpha and beta receptors, and ACE inhibition. Nevertheless, the hypertrophy remains, meaning that this is a specific factor for uremia which we are not controlling to any extent. We are absolutely losing that battle currently. We don't know. Is this a reason to think about FGF23 in the clinical medicine? I think it is, but it has to be proven by appropriate, of course, clinical trials. This is cardiac hypertrophy again in subtotal nephrectomy, and you see when you do subtotal nephrectomy, you see again that the cardiac hypertrophy is dramatic, and even with treatment with furosemide and metoprolol, it's no changing. So this is an intrinsic system. And this ventricular hypertrophy has its classical afterload and preload components on top of that. And that's the message of that from the first part, that renal failure goes along with volumia, and it changes in volume, of course, changes in a lot of neurohumoral activation, changes in active vitamin D is decreasing. You will see that vitamin D, I will give you one slide on that, may be interesting. Why is all the retrospective observational studies in dialysis in patients with vitamin D, normal vitamin D, versus depletion of vitamin D, why all those studies are convincing that the survival is better with vitamin D? Of course, we need prospective control trials, which are not the case currently. But the number of observations is so overwhelming that there seems to be also a role for vitamin D in the protection against cardiac hypertrophy. The same is true for PTH, high PTH. The same is true for many other things. And I think, personally, that also the uremic toxins has been a long, long history of a long list of many, many things. And of course, the kidney, when the kidney is failing, there is an accumulation of many things. But one of the things will come out really outstandingly as being experimentally and also clinically now is endoxyl sulfate. Endoxyl sulfate is one of the accumulated products in renal failure. When you remove that, you have an improvement. Even in the clinical medicine, there is already a lot of interesting observations. It's one of the first factors of uremic toxins which has been identified as a possible important thing. Cardiac fibrosis, no problem. If you do biopsies and post-mortem biopsies and you look to the fibrosis in the patient, dialysis patients, and when the cardiac fibrosis is high, there is a higher mortality, but this is straightforward to do that, to do that observation, but it's good to register that in a scientific way. The fibrosis is probably stimulated. Some people believe that PTH. I do not think that this is a major issue. A major issue is certainly phosphate. Hyperphosphatemia in experimental models on the level of the heart, the level of the kidney, etc., is certainly a factor which induces fibrosis. In addition, if you do ACE inhibition and adrenal receptor blocker, you can improve, you can reduce the cardiac fibrosis, so probably this angiotensin 2 endothelin TGF-beta fibrosis axis is playing a role in this process. Here you see the fibrosis. We all know, we are very familiar with the fibrosis of cyclosporin, which is a drug, such a powerful drug, would change the picture in renal transplantation. In the meantime, as said yesterday, I think by Miguel, this is wonderful drug, but also kills the kidney on long term, and also in patients with heart transplants. Patients with heart transplants have a major problem with their kidneys if you use cyclosporin. And this is the typical picture of this striped fibrosis at the light magnification. This is a higher magnification. And the interesting point is that certainly sirolimus can certainly be used as a less fibrotic agent. However, we now know that sirolimus has such a long list of other complications that the debate is still going on if this drug has a definite place in transplantation. What is the functional consequence of this cardiac fibrosis? The consequence is reduced left ventricular compliance and arrhythmia. Arrhythmia is a very important issue in dialysis. Patients with dialysis develop very frequently arrhythmic diseases, which are much more frequent than observed in the normal population. And this is here very sophisticated terminology, which I stop because I'm not an expert in that, but I know just that fibrosis induces a high electric resistance. I can still follow that. Delayed spread of action potential, okay. And re-entry of type arrhythmia, that's the science I know. These are the different mechanisms, but I let to the interested people to read something more about that. There is a microvessel disease in renal failure relating to arterial thickening and capillary deficit. And here you see it. Again, the capillary deficit of hypertrophied hearts in uremic patients, this again is clinical medicine, controls essential hypertension, uremia, and you see the length density of the capillaries in the heart are dramatically decreased in uremia as observed recently in recent papers. In addition, the cardiac fibrosis I alluded to after subtotal nephrectomy and receiving ACE inhibition, their fibrosis is reversible, but the capillary deficit is not. So that's again a disease, a cardiac disease, a cardiac lesion, which is certainly not controlled by the drugs we have for the moment. These two factors induce impaired oxygen delivery, of course, and impaired ischemia tolerance. Can be normalized in experimental conditions. There is a role for calcimimetics showing clearly that there is a normalization of capillary length density and interstitial volume density, promising results. We don't know, of course, nothing about the clinical application of that. And here is calcitriol again. Calcitriol vitamin D restores the capillary deficit and interstitial fibrosis in the heart. So this is again an enormous support for the fact, although the prospective trials still have to be done. We don't have to wait sometimes in medicine, not to the controlled, prospective controlled RCTs. Before we take a decision. I take the decision to, as soon as you see a patient with a renal failure of his, with CKD 3, 4, proteinuria, and the whole picture of a renal disease, you should evaluate vitamin D, and you should substitute vitamin D with cholecalciferol, which is a non-expensive thing, and you can normalize perfectly these concentrations. So sudden death is an important point. General population sudden death versus patients. This is 100 times more frequent in dialysis. Here you see the temporal relationship between the duration of the dialysis, hours from the start of dialysis, and the sudden death. And also the factors playing a role. Phosphates play a very important role in sudden death in dialysis. So hyperphosphatemia should be treated aggressively in the dialysis and end-stage renal failure population in order to avoid this. Sleep apnea is one of the reasons of sudden death. And again, we are not lucky, the patients in our centers, because the fact that the prevalence in the general population, that is the prevalence in the dialysis population, is very high of sleep apnea. And if you see this famous average nocturnal oxygen saturation, if it is more than 95% or lower than 95%, you see the dramatic difference. So that can be, there we can play a role, because the factors, the risk factors to develop sleep apnea are mainly obesitas, alcohol, and smoking. So these are three factors which are under the control of the medical team responsible for the patients. So and this is a preventive measure. You cannot do that when you are on the bedside of the patient. You have to do that through education and stubborn education and repeating still the same things about these three risk factors. The long QT syndrome is very well known in dialysis, is very frequent in dialysis, and is due to reduced potassium channels and an increased sensitivity of the remaining potassium channels. And what is important again for us clinicians, we should not use sotalol, which is inducing this QT prolongation. So sotalol has absolutely no role at any extent in our patients. The same is true for erythromycin and antidepressants. And inhibitors of CYP3A4, like macrolides, ketoconazole, and grapefruit. And that's very important because grapefruit has been discovered only 10 years ago as being one of the causes of this very important complication. A study in dialysis patients with a huge number of cardiac arrest, and 10% survived this cardiac arrest. And one of the factors who protected to a certain extent is aspirin, beta blocker, and an ACE or an ARB treatment. Finally, the interventions. What can we do? We are not very well armed against some of these factors because, as I said, we don't know the physiopathology. We know it is related to renal failure, but we don't know the exact causes. So as long as you don't know the exact cause, it's very difficult to do primary prevention. Anyway, the classical traditional factors, I will not repeat them. This has been done several times already in this symposium. There are a lot of renal factors. Anemia, calcium phosphate, proteinuria, oxidative stress, etc., all these things are related to renal failure and to dialysis. So we should try to correct the anemia, etc., and having a normal calcium phosphate balance. When it is occurring, it's occurred very quickly. It occurs at the level already with the GFR just below 100. It starts, the risk to develop cardiovascular disease is present. And here I have a dramatic slide that if you do in advanced CKD, multiple risk factor intervention, no longer any benefit on cardiovascular disease. So this was a study on 200 patients with CKD 4-5, 2-year intervention, conventional versus multiple risk intervention. There was absolutely no significant difference of cardiovascular events in this cohort of patients, showing that we are doing something which is very difficult to be successful in the treatment of a far advanced stage of renal failure and cardiovascular disease. Some people believe, and this has been discussed already some days ago, in therapeutic clinics and to intervene very early in the phase of renal failure to combat, of course, the hypertension. We have an extensive discussion here yesterday. I have not to come back to that. And to add systematically a statin, calcium antagonist, And I think here, I cannot read that. And then beta blockers systematically in order to control optimally. And I think here it's somewhere written to be below 120 and 80. I cannot agree with that. Since yesterday we have developed several arguments that this is a little bit too far, certainly in certain patients. But that you have to do a certain aggressive treatment at early phase can not be debated. The only problem is that we have not to go until 120 and 80. RAS blockade, what can we say about that? This has been shown, I think, also the trandolapril, which is absolutely not of any benefit in patients with normal renal function, but is of benefit in patients with already some degree of renal failure. That's interesting. The same is true for fosinapril and maybe other ACE inhibitions. And here is the SARTAN study, which also shown a benefit of survival of dialysis patients. So here I want to make a point, a personal point. There is a lot of lobby by the pharma industry because there is a disturbance in aldosterone in renal failure, accumulation of aldosterone, and people start to promote anti-aldosterone preparations in the treatment of patients with renal failure. I disagree totally with that. In my experience, and not only in my experience, in many experience, we have done that, but the number of patients with hyperkalemia, uncontrollable hyperkalemia, is very high. So the risk for death of hyperkalemia in patients with already high risk of QT prolongation, etc., all the things I have told you, but hyperkalemia is too high to allow. And this is typical for what I call fraud science. They say here there is no difference in potassium. This is standard deviation. You should not present that in that way. You should show box plots, showing all the data in one figure. Because in this type of complication, you will have only maybe 1 or 2 out of 500 patients would die from that. But this graph can never show that. If you show a box plot, you will see that some of the patients will have a very high hyperkalemia. So we should be very critical in that. Sympathetic activity, this is well known that the DOP study shown that less mortality in those on beta blockers, and that's an important observation. Here again, confirming with carvidiol. And here again, by a prospective study in dialysis patients to have some protection. And reducing of mortality. Lipids, catastrophe. Here you see the study of Warner in New England Journal of Medicine with atorvastatin, and you see that there is absolutely no change of the survival cumulative incidence of cardiovascular events, except here after some time, but it is not statistically different. They did every effort to have a certain statistical significance, and they finally claimed that in the high cohort of more than 145 LDL cholesterol, there is some benefit of using a statin. But that's typical pharmaceutical interpretation of data in order to at least defend a small amount of patients and save one patient out of 1,000 and then put that on the market and everybody eats atorvastatin. It is part of the game. Here you see a slide, and it's already alluded to, of all the big studies, and there are more, but I just have made the list of most important ones, that not able to reject the null hypothesis in the erythropoietin study, in a dialysis approach study on membrane flux, in peritoneal clearance, in correction of anemia, in atorvastatin, and in phosphate binder. Once you have in this phase of late phase of renal failure, and particularly in dialysis, that this is such a complicated story of heart failure, left ventricular hypertrophy, cardiac fibrosis, microvascular disease, ischemia, that it is unlikely that one single golden bullet will ever eliminate all cases of cardiac mortality in renal patients. So my major point is we should have, and I think that the Egyptian Society of Nephrology has an enormous challenge in order to get your patients more earlier in your consultation rooms, that you can do proper secondary prevention. And I think that's the future for this. Thank you for your attention.